Hello and welcome to Davos in Switzerland. I'm Ken Johnson and I'm the chairman of the AOVET R&D Commission. Today we have 4 presentations that we'd like to bring to you from young investigators, and this we think provides an opportunity for these people to talk about their research and have it discussed in a public forum, and also to encourage them to continue with their research and think about applying for a research grant from AO that's available on an annual basis. Today we're here with a panel of 4 well-known surgeons who are going to be discussing this presentation. We have Dr. Simon Roe with us, coming from North Carolina via Zoom, Professor Matthew Allen from Cambridge in the United Kingdom, Dr. Michael Kowaleski, Tufts University in the US, and Dr. Jeff Watkins at Texas A&M University. To begin, I want to introduce to you Dr. Brett de Bruyn from Perth in Western Australia. Hello, Brett. It's good to have you here on the program.
Thanks for having me, Professor Johnson. It's a pleasure to be here and I'm excited to present our research.
Good afternoon. I will be presenting our research investigating the relationship between orthogonal plate application and primary plate working length on construct stiffness and primary plate strain in an in vitro fracture gap model. Orthogonal plating is the application of 2 plates 90 degrees to one another on the same bone. It is intuitive that orthogonal locking plates will have higher stiffness and lower strain compared to single plates. However, this has not been evaluated in the veterinary literature. One feature of plate configuration that we do know to affect stiffness and strain is working length. This is the distance between the innermost screws either side of the fracture gap and is shown by the red arrow in this image. Studies have shown that as working length is extended, stiffness is lower and plate strain is higher. Selecting the shortest working length will therefore maximise stiffness and minimise plate strain. However, this is limited by fracture configuration. The image on the right of this slide highlights the impact of fracture configuration on working length. The fracture on the left would permit application of a plate with a short working length, as shown by the red arrow, while the fracture on the right would require a plate with a longer working length, as the configuration prohibits a short working length repair. The effect of an orthogonal locking plate on stiffness and plate strain across different primary plate working lengths is not known. The aim of this research is to therefore determine the effect of adding an orthogonal 2.7mm LCP on construct stiffness in bending and in torsion, and on plate strain in bending in a fracture gap model with a primary 3.5mm LCP at short, medium and long working lengths, with constant screw number in the primary and orthogonal plate. The first research hypothesis is that as working length is extended, there will be incremental reduction in construct stiffness and incremental increases in plate strain, meaning that stiffness will be highest and strain will be lowest in the shortest working length constructs. The second and third research hypotheses are that the addition of an orthogonal plate will result in higher construct stiffness in bending and torsion and lower primary plate strain in bending at each working length. Synthetic fracture gap models were assembled using Delrin tubes with a primary 3.5mm LCP and an orthogonal 2.7mm LCP. Plates were applied with 1mm standoff from the Delrin and a 10mm fracture gap was maintained. The primary plates had 3 bicortical locking screws per fragment, indicated by the open circles in the image. Screws were applied in 3 different configurations to create short, medium, and long working lengths, with working lengths shown by the red arrows in this image. Orthogonal plates were added to each construct after initial testing and were applied with 2 bicortical locking screws per fragment using constant screw configuration, as shown by the black arrows. The orthogonal plate screws were eccentric to the innermost screws in the primary plate, so that working length was always determined by the screw configuration of the primary plate. 6 replicates at each working length were tested without and then with an orthogonal plate for 36 constructs to be tested. Construct stiffness was measured under non-destructive 4-point bending and axial torsion. Strain was measured during 4-point bending using digital image correlation at the axial plate region over the fracture gap, as highlighted by the red rectangle in this image. A 2-factor general linear model was used to assess a fixed effect of working length and use of an orthogonal plate and their interaction on stiffness and strain. Where significant interaction was detected, comparison within and across working lengths was performed. The results for bending stiffness are presented on the slide. The histograms represent the mean for each construct, and the error bars are the 95% confidence interval of the mean. The constructs are across the x-axis, with the short working length constructs on the left, medium in the middle, and long on the right. The shaded bars shown here represent the single plate constructs without an orthogonal plate. Bars with different lowercase letters were significantly different. Comparison across single plate constructs showed that constructs with the shortest working length had the highest stiffness, and there was significant incremental reduction in stiffness as working length was extended. The solid bars represent the orthogonal plate constructs for each working length. The addition of an orthogonal plate resulted in significantly higher stiffness at all working lengths examined. Importantly, the stiffness reached through orthogonal plate application was not different across working lengths, which is highlighted by the red bracket on this graph. This means that the effect of extending working length on construct stiffness was completely mitigated by the application of an orthogonal plate in 4-point bending. In torsion, comparison across working lengths again showed lower stiffness as working length was extended, with the short and the medium working length constructs having higher stiffness than the long working length constructs. Application of an orthogonal plate resulted in significantly higher stiffness at medium and long working lengths. Higher stiffness reached through orthogonal plate application in a long working length construct resulted in stiffness that was not different to a short working length single plate construct. The following slides show the results for primary plate strain. Comparison across working lengths showed higher strain as working length was extended, with the short and the medium working length constructs having lower strain than the long working length constructs. Application of an orthogonal plate resulted in significantly lower strain at all working lengths. Like the results in torsion, orthogonal plate application to a long working length construct resulted in primary plate strain that was not different to a short working length single plate construct, and it was lower than a medium working length single plate construct. Given our results, we accepted our first research hypothesis. In our model, short working length constructs had the highest stiffness and the lowest strain, and there was significant incremental reduction in construct stiffness and increases in primary plate strain as working length was extended. We accepted our second research hypothesis as the addition of an orthogonal plate resulted in significantly higher construct stiffness in bending and in torsion for all working lengths except the short working length in torsion. We also accepted our third research hypothesis, with significantly lower primary plate strain at every working length following orthogonal plate application. So how might this inform our practice? Our results have shown that if you are forced into a long working length repair due to the fracture configuration, or if a long working length repair is chosen, such as with an MIO repair, then application of an orthogonal plate can overcome the detrimental effects of a long working length on stiffness and primary plate strain. Additionally, for any working length, if a fracture has poor biologic assessment and prolonged healing times are expected, or if the biomechanical assessment of the fracture is poor and excessive limb loading is expected in the post-operative period, an orthogonal plate should be considered to extend the fatigue life of the implants. I would like to thank my co-authors and acknowledge funding from the Australian Companion Animal Health Foundation and ZebraVet and Synthes. Thank you for the opportunity to present our research.
Thank you very much, Brett. I'll hand over now to Simon to address some comments to you.
Thank you.
Hi, Brett. Thank you very much for that presentation and all the effort you put into this research. Really interesting project and some great data for us to contemplate as we plan managing particularly our complex types of fractures. I had a couple of questions, and the first one is, when you added that orthogonal plate, the stiffness in bending rose, which we sort of expect, but there was no longer any impact of working lengths. Why do you think that is the case?
Thank you, Simon. And the question was that why is it that the effect of working length was mitigated, if you like, by the addition of an orthogonal locking plate in bending? And I think it comes down to the overwhelming impact of the orthogonal plate on construct stiffness in bending. So the orthogonal plate in this situation, the 2.7 millimeter LCP that's added to the construct, contributes about 75% of the overall stiffness when tested in 4-point bending due to the AMI calculation. So I think that that overwhelming contribution to overall stiffness, I think that the relatively smaller effect of working length is overcome.
I suppose that actually made me think the other thought is, did you test plates just with the orthogonal plate or just with the 2.7 plate, not the orthogonal plate, and see, with that 2.7 plate in that orientation to the direction of bending would obviously have a very high area moment of inertia. Any thoughts on that?
Yeah, so I suppose the comment is that, perhaps we could have tested simply just the orthogonal 2.7 millimeter plate when loaded, side loaded in 4-point bending to maximize its properties in stiffness. In this situation, I think it's important to realize that ultimately this is just a model, and that testing in true uniplanar 4-point bending is very much a in vitro testing method and doesn't reflect the loading conditions that would be expected in a clinical case. So whilst measuring that may provide some use and would certainly be interesting, I think that probably the clinical relevance of that information on its own is perhaps limited, but certainly to investigate the effect of differing plate positions on construct stiffness through 4-point bending would be an area of future research for sure.
Yes, I frequently get into discussions on where the best position for a distal radial plate is, and cranial versus medial for this very reason is often comes up for discussion. Another question I had, you chose the area that you chose to assess strain in your plates was sort of in the, what is somewhat more the solid section between the holes. And wondering why you chose that rather than maybe in the section of the plate that's beside the hole.
So the question was, why did we choose the axial plate region between the holes over the fracture gap rather than the abaxial plate regions along the side of the combination screw hole? The region of interest that we selected was chosen because we felt that it was the most consistent region across all working lengths, that was not abutting adjacent screws and was not bound by screws in the different working length constructs. This region we felt allowed relative comparison across working lengths under specific loading conditions. And, again, very specific to our loading conditions, but certainly allowed for good comparison. Previous investigations from our institution with work from Bird and others in 2020, Evans and others in 2023, have shown that whilst this might not necessarily be the area of peak strain that's been shown in some studies, as working length is extended, it does increase. So, I think it's a point of comparison. It's not trying to suggest where the location of peak strain would be. Strain mapping of the entire implant would be required for us to make inferences about where we expect, where the peak strain is and where we would therefore expect the plates to perhaps fail.
Very good. We have time. Another question. One of the things that is always balanced, you sort of inferred this a little in your conclusions, is adding an orthogonal plate is going to do a little more biological, be a little more biological invasive, do a little more damage. So I suppose one of the questions is the biological impact of concern relative to the mechanical advantage?
Yeah, and so that's a great question. The question is, does the biologic cost, if you like, of placing an orthogonal locking plate outweigh or offset the benefit that you gain from it? I think that in a clinical scenario where you feel that if your biologic assessment is poor, such as in a comminuted fracture, the marginally increased dissection required to place an orthogonal plate in most cases, certainly if you're placing them via open reduction and internal fixation, in most cases you'll have the bone normally two surfaces exposed anyway. But if you deem that it's necessary to increase stiffness or perhaps lower strain because you're worried about perhaps a long healing time, I think that an orthogonal plate should be justified. We don't have the clinical aspect of this research to make conclusions on that, but I think that the benefit is clear from a stiffness and from a strain perspective. We've shown that with lower strain and higher stiffness, it would be expected that the fatigue life of these implants would be longer. So, the biologic cost is likely offset if it's deemed necessary in a clinical setting. I mean, it should be noted as well that these can probably be placed minimally invasive, and we certainly have done that at our institution. They're also probably well suited to minimally invasive placement in that in most of those repairs, they'll be selecting a long working length, and that's probably one of the places that, from our research, the orthogonal plates tend to shine.
Very good. Then last point, I suppose, is to then the counterbalance between an orthogonal plate and an IM pin as a way of reducing strain in the long working neck type of construct. Any comments on when is the right time? When is adding a pin enough? And the disadvantages of that versus the advantages of an orthogonal plate?
Yeah, so the comment was, when would you consider an orthogonal plate as an augmentation of your repair versus perhaps a plate rod construct or an intramedullary pin in combination with your plate? And I think that the benefit of an orthogonal plate, or the challenge, if you like, with a plate rod construct, is that often particularly if you're in a long working length fracture, you're often running into situations where bone stock is limited proximally and or distally. And if you're placing a plate with a combined intramedullary pin, it may be that you run into the IM pin with your screws, and then instead of being able to place bicortical locking screws, you'd be forced into placing monocortical. Similarly, I suppose, particularly in the long working length scenarios, orthogonal plates can be really beneficial. A second kind of arm of this research that's not been presented here, but is looking at screw number, and it can be used to increase screw density where there's limited bone stock. So I think, if you've got a long working length fracture and you're worried about getting bicortical screws, I think that the orthogonal plate can help you do that, where perhaps an intramedullary pin, particularly with the fixed angle that your screws are placed at through a locking plate, you might not run into that with a plate rod construct.
That's excellent. Thank you very much. A lot for us to think about as we plan management of these complex fractures.
Thank you, and thanks for having me.
Thank you very much, Brett, for your presentation. That was very interesting. And thank you, Simon, for your comments. We'll come back to you at the end of the presentations. The next presentation comes to us from Zurich, and I'd like to introduce to you Dr. Heidi Radke from the University of Zurich. Welcome on the symposium, Heidi. Good to see you.
Thank you very much, Ken. It's a pleasure to be here, and I'm delighted to be able to present our work. Thank you very much for giving me the opportunity to speak about our work on owner-reported outcome measures and present you this project on linguistic validation and cross-cultural adaptation of owner-reported outcome measures used in canine orthopedic care for the German and Spanish-speaking population. Currently, there were no translations in German and Spanish of the Canine Orthopedic Index, the COI, and the Liverpool Osteoarthritis in Dogs instrument, the LOAD, available. This was an observational, prospective and multi-center study with a sample cohort with the objective to develop universal German and universal Spanish versions of COI and LOAD used in canine orthopedic care that are well understood by the target population. To ensure that the owner or observer reported outcome measures, the OROMS, measure the same mental, physical and social constructs across languages, the process of linguistic validation and cross-cultural adaptation is crucial and needs to be carried out with great care according to predefined standards. The methodology followed the gold standard PRO, patient-reported outcome, consortium's translation process, meeting the standards recommended by the International Society of Quality of Life Research. The study was performed in 2 phases and multiple steps, involving professional interpreters and veterinary specialists, the country investigators. Alexander Jürgens from the AO Innovation Translation Center, the AO ITC, and myself teamed up with collaborators in Spain and Colombia, the orthopedic surgeons Pilar Lafuente and Natalia Reyes. The study was funded by AO Vet. We worked with the commercial collaborator Facet Trans, who are specialists for the translation and linguistic validation for patient-reported outcomes in people, and it was their first time to work with veterinary specialists. The target population were dog owners or dog carers of dogs with osteoarthritis of elbow, hip or stifle. They had to be German or Spanish speaking, with reading literacy to complete the questionnaires, and for the Universal German we interviewed 5 dog owners in Germany, Switzerland and Austria each, And for Universal Spanish, we interviewed 5 dog owners in Spain, the United States, and Colombia each. In phase 1, items, response options, and instructions, respectively background section items, were identified for all questionnaires with conceptual or literal wording differences, which were resolved through a stepwise deliberation. Linguists and veterinary expert panel discussion led to harmonized versions to be applied on patient owners in cognitive interviews according to the PRO consortium guidelines. For example, the English words exercise or to exercise required different German words to be used in the context of different items in order to better reflect the original English version and intent. In phase 2, the cognitive interviews, the participant characteristics were found to be adequate. The items were generally easily understood by the participants. In few cases, participants suggested alternative words or phrases. Few items were changed after the cognitive interviews. Final consensual translated versions were obtained. The stepwise approach and the centralized revisions were key elements throughout the process in order to identify and address discrepancies and to document changes. Study limitations include the absence of psychometric property analysis and its validation, including acceptability, test-retest reliability, internal consistency, and construct validity. These are important aspects to be investigated in follow-up studies. This project has clinical relevance because it allows to collect the owner perspective on the treatment of dogs with osteoarthritis in 2 additional languages using COI and LOAD. And it has scientific relevance because it serves to familiarize the veterinary community with the up-to-date way of internationalizing OROMS. An important learning point was this collaboration between the linguists and the veterinary professionals. And this is certainly a recommendation coming out of this experience to involve linguists early on in any processes of OROM development. This study sits within a wider project I have been working on with the AOITC and have been supported by AOVET with the vision that routinely OROMs will be collected through web and app-based electronics. A key aspect is the successful integration with the electronic medical records. That will allow us to use OROMs in routine clinical care. It will facilitate the use of OROMs in clinical trials and will make multi-center trials much easier. It will also help with the OROM data analysis, the reporting and the interpretation of data, and overall will support to promote excellence in patient care and outcomes. We've done other work around OROMs together with AOITC and supported by AOVET. We trialed to routinely introduce OROMs into the routine orthopedic practice of the University of Cambridge. That was still paper-based and app-based, but not connected to clinical records, and that showed that it was very laborsome and not feasible in that form. We surveyed internationally the AOVET community around their perception of OROMs and their current use of OROMs, and results showed that the most important prerequisites for implementing OROMs in routine clinical practice were user-friendliness, time efficiency, and interpretability. A high number of vets indicated that they would implement OROMs if adequate tools, technologies were available. And we did a quality assessment of available OROMs, which demonstrated that LOAD, COI, and CBPI provided evidence of sufficient content validity and could be recommended for use in dogs with osteoarthritis. We have done practical work also to develop a pilot registry that allows comprehensively and routinely the registration of a wide spectrum of common canine orthopedic conditions, with the aim to cover all routine clinical practices such as conservative, medical and/or surgical treatments, and to capture data such as clinical presentation, treatment, complications, and observer-reported outcomes. The results of the present study will advance the aim of the overarching project of becoming a multinational database, attractive to a wide range of veterinarians and facilitating large-scale data collection. The results of this study will help to explore the outcomes of canine patients with osteoarthritis in an international multi-center setting. Further research around OROMS is planned. We want to assess the performance of the translated OROMS. We want to look into the performance of OROMS for other orthopedic conditions. We are interested in the performance of quality of life assessment tools for the assessment of orthopedic patients. And there is still quite a bit of work to do to facilitate the clinical interpretation of OROMS. And we are keen to use the pilot registry clinically as a proof of concept. I would like to acknowledge my co-authors and collaborators of this study and the other work around OROMS. That's a fantastic aspect of my work, these collaborations. I couldn't do any of that on my own. I would like to close with this quote from Atul Gawande, and thank you very much for your attention. I look forward to our discussion. Thank you.
Thank you, Heidi, for that very interesting presentation. It clearly represents a lot of work. Pass you to Matthew, and you'd like to make a comment or questions, please.
Thank you, Ken. Yeah. Heidi, thank you very much for an excellent presentation, very clear. And it's quite complicated stuff. So one of my first questions is, I think a lot of the audience will have heard about PROMS and OROMS, but perhaps you alluded to the fact there's some limitations with the current study because it doesn't obviously do everything that needs to be done. Could you tell us a little bit about what does it take to get through, for example, validity measurements, responsiveness and reliability? Just briefly, what does that look like in terms of a study?
Yeah, so for that, these OROMS are currently developed, and also there is a body of validation for osteoarthritis. So you need for this further psychometric testing, you need a quite uniform group of dogs to then ask the owners to fill out the questionnaires. And that these will then provide the data to provide further psychometric testing.
Yeah, okay. I think, because you mentioned, I think it's a really important point that these are going to be tremendously useful for multi-center transnational trials. But obviously it will depend on them being equally responsive in each language. And I guess one of the concerns I would have is that may be challenging. It may not actually be true. Simplistically, as I was listening to your talk, I was thinking it'd be really nice to have some bilingual clients and then have them do a retest in 2 different languages and see if you got the same scores from their dogs. But perhaps that's something that's a bit pie in the sky. But I think the importance for the audience is that this needs to be validated, and it needs to be validated not just for language, but also for activity or for the disease condition, and that can take some time.
Absolutely. Our situation in veterinary orthopedics is very different from the situation of orthopedics and patient-reported outcomes in people, where there is a large number of instruments validated for specific conditions, and also quality of life assessment tools. And in our field, we only have a little bit more than a handful of instruments, and most are currently only validated for the assessment of osteoarthritis. So we're really keen to test these instruments for their potential to be used for other conditions. And to be able to do that, it's of great importance how these instruments have been developed. And therefore, the Canine Orthopedic Index is particularly interesting because that has been developed already with the idea in mind that it can be used also for other aspects of orthopedic disease, and owners with dogs with other orthopedic disease have been involved in the development of the instrument.
Okay.
So whilst it has not been validated yet, it has a great potential to be in future.
And what's the situation? I noticed that in your earlier papers, you established that COI and load, but also the brief pain inventory were also appropriate. Any thoughts on using CBPI and validating that linguistically and using that, or are you going to move ahead with load and COI?
We didn't translate the CBPI because there is already a well-done translation in German, and a team in Spain has been working on the Spanish translation. So yes, also the CBPI is an instrument we want to look into further. And I want to also say the results of our quality assessment, that was a moment in time assessment. So that means the instruments which were shown at that time not to have sufficient evidence yet also means that further evidence can be developed for them. At that time, there was just not enough evidence to judge if they can be recommended.
Okay, so it sounds like there's a fair amount of work still to be done. Have the instruments developed in Germany and Spain, the CBPI, have they been through a similar process to yours, or a sort of a light version of that? Have they been translated, or have they been translated and then linguistically assessed?
The CBPI in German has, but the Spanish has, I think, is still being done. Has been done in a more traditional way. Also, earlier there are a few translations already available, but that has been done usually with a vet who is bilingual, and then there is a forward translation and one backward translation, but no cognitive interviewing process, for example. And also with the PROs, the patient-reported outcomes in people, there has been a tremendous development in the last century, I would say, with recognizing how important it is to do it really in a scientific process, the process of linguistic validation and cultural adaptation. And that's also why strict guidelines have been developed. And we think it's important to also use them in veterinary medicine.
Great. Well, we look forward to seeing these developed and hopefully being validated and applied, because, of course, to do multi-centres around the world, we're going to need instruments exactly like this. So thank you very much for your work on this and for spearheading this initiative.
Thank you very much, Matthew. Thanks again to the panel and for the opportunity.
Thank you, Heidi, for that really interesting presentation. It represents a large amount of work, and we're really looking forward to hearing more about this in the future as you continue this direction. Thanks for joining us on the symposium.
Thank you very much. Once again, it was a pleasure. Thank you.
Our next presentation is coming from the Netherlands, and introducing Irin, who's going to speak to us about her research. Thank you.
Thank you, Dr. Johnson. I feel really honored to be here and have an opportunity to share my research. Good afternoon, everyone. My name is Irin Kwananocha. I want to express my appreciation to the AOVET for allowing me to share my research on the topic of a long-term outcome of using personalized 3D printed titanium implants for acetabular limb augmentation to treat canine hip dysplasia. Hip dysplasia is a common orthopedic disease in young dogs. It leads to joint laxity and pain, and may develop into severe osteoarthritis. The treatment options for canine hip dysplasia consist of conservative treatment, and surgical treatment. The surgical treatment aims to inhibit or minimize joint subluxation by modifying the dorsal acetabular. However, the current surgical treatment, like juvenile pubic symphysiodesis and double pelvic osteotomy, have limitations such as restricted surgical age, invasiveness, and high complication rate. The shelf arthroplasty is a common technique in human medicine, but few applications in dogs. To address these challenges, we are developing a patient-specific 3D printed shelf implant for minimally invasive treatment with reduced complication rate. This animation is demonstrating the concept of acetabular limb extension, or the A6 implant. This dysplastic hip shows subluxation sign. When the A6 implant is positioned, the hip stability is improved without limiting the range of motion. The objective of this study is to provide an alternative treatment option to treat canine hip dysplasia with a more predictable outcome, faster recovery time, and lower risk of complication. We hypothesized that the A6 implant will maintain its clinical functions in the long term with low morbidity and high implant survival. The inclusion criteria of the study dogs including of young dogs older than 6 months with clinical signs of hip dysplasia, positive autonomy test, show evidence of hip dysplasia by radiograph, no or mild radiographic evidence of hip osteoarthritis. For the material and methods, when the patient with clinical signs of hip dysplasia met the inclusion criteria, the CT scan will be performed for preoperative planning and implant design. The implant will be designed to extend dorsal acetabular limb without interfering the range of motion. Then the implant will be printed and sent back to the hospital for operation. The duration of this process is 8 weeks. The implant was printed from titanium alloy and consisted of 2 parts, the bone attachment part and the rim extension part. For the bone attachment part, the inner surface is a porous surface for osseointegration, and there is a frank at the ventral side that helps to place the implant in the designated position. For the rim extension part, there is a 2 mm offset at the inner side of the implant for interposition of the joint capsule. The implant is placed at extracapsular of the hip joint. There are 5 visits, including preoperative day, the day of surgery, 1.5 months, 3 months, and 12 months after surgery. We monitor 5 parameters consisting of radiographic evaluation using CT scan, force plate analysis, Helsinki Chronic Pain Index owner questionnaires, and autonomy test. For the radiographic measurement, the Norberg angle and percentage of femoral head coverage were measured from coronal CT scan. In addition, the osteoarthritis was scored according to the site of osteophyte detected at the cranial and caudal acetabular limb and the femoral neck in both coronal and transverse CT. Then the osteophyte site was tied into a 4 points of osteoarthritis score. There were 34 dogs with 61 hips enrolled in this study. The median age was 12 months and the median weight was 27 kg. From 34 dogs, 7 dogs underwent unilateral hip surgery and 27 dogs underwent bilateral hip surgery. The median lead time from preoperative day to the day of surgery was 74 days, and the average surgical time was 91 minutes per hip. The intraoperative autonomy test was performed. Before implantation, the autonomy was clearly positive, and it became negative immediately after implantation. In this study from 61 hips, there were 2 hips still show positive autonomy after implantation, but the angle of reduction and subluxation was decreased. For the radiographic measurement, the Norberg angle and femoral head coverage significantly increased immediately after surgery and retained their level in the long term. For the osteoarthritis progression, graph number 1 shows a significant progression of OA score in the lead time. However, after implantation in graph number 2, the OA score did not significantly change from the day of surgery to 3 and 12 month follow-up. In graph number 3, when we categorize the study hip according to the baseline OA score, we found a significantly difference in osteoarthritis progression of 1 year between OA score 2 group compared to OA score 1 group. Graph number 4 reported the progression of osteoarthritis in 1 year in different FCI score categorizations, although a significant difference was not observed. The FCI score E group showed the biggest enlargement of osteophyte in this study. Force plate analysis showed a non-significant change in peak vertical force. However, it returned to the baseline level at 1 year follow-up. The Helsinki Chronic Pain Index questionnaire showed significant improvement at 3 and 12-month follow-up compared to the pre-treatment value. The pain scale gradually decreased over time. This is a post-operative CT scan of obelisks, the 13-month-old Bernese Mountain Dog, when he underwent bilateral A6 implantation in a single session. For another dog, 4 is a 13-month-old Labrador Retriever, when underwent bilateral hip surgery. On the left side, show the picture of pre- and immediate post-operative X-ray, and on the right side, show the picture of CT scan at 1 year follow-up. For the clinical side, Flo could walk without any assistance in the next day after surgery, which means this surgical technique offers rapid recovery due to minimally invasive approach, and he also had a good ability to exercise with good hip range of motion at 1 year follow-up. In this study, we found 4.9% minor complications and 9.8% major complications. The minor complications were found in 3 hips from 2 dogs, including intermittent lame, and it recovered by pain medication. The major complications were found in 6 hips from 4 dogs, including implant failure in 3 hips, severe osteoarthritis progression in 2 hips, and septic arthritis from chronic cystitis in 1 hip. The revision surgeries were performed by removing the A6 implant combined with total hip replacement. For the discussion, the A6 implant effectively augments the coverage of the femoral head and eliminates the laxity of the hip joint immediately after surgery and retains its function in the long term. Although the force plate did not show a significant change, the Helsinki Chronic Pain Index questionnaire revealed a significant decrease in activity-related pain, suggesting reduced hip pain and improved exercise tolerance. Due to the less invasive approach, this surgical technique exerts rapid recovery. The dog could walk non-assisted in the next day, and they need to be hospitalized for only 1 night. Therefore, this technique can be performed as a single-stage bilateral hip surgery. From the high amount of OA progression found in the dogs with OA score 2 and FCI score E, this surgical technique is not suitable with the patients that have severe hip laxity and moderate to severe hip osteoarthritis. Severe hip laxity, rapid OA development, and concurrent for limb lameness were indicated as risk factors that cause major complications. In this study, 2 implant failures were found in a dog with bilateral humeral condyle fractures 3 months after A6 implantation. Another implant failure was found in a dog with contralateral hip luxation. Therefore, case selection at the moment of inclusion and the concurrent injury that occurred during the initial stage of osseointegration are critical for implant survival and successful outcome. However, the long-term survival of the A6 implant appears promising in this study. When a serious complication develops, revision surgery with total hip replacement can be performed immediately following the removal of the A6 implant. There are limitations in this study. Firstly, the preoperative CT is needed for implant design and additive manufacturing. Secondly, although this is a patient-specific implant, the fluoroscope is required during surgery for implant positioning. Therefore, in the further study, the surgical guide should be developed. Lastly, due to the pandemic of corona during the study period, the implant production and patient management were delayed, which increased the opportunity for OA progression, caused imperfect implant positioning. To summarize, the A6 implant enhances femoral head coverage, eliminates subluxation, and provides long-term pain relief with minimal complications. Therefore, this technique is a secure and viable option for clinical applications. Bilateral A6 in a single session is feasible and limits OA progression. However, to avoid complications, reduction of the lead time and strict inclusion criteria are essential. I would like to acknowledge and thank my supervisors and the research team from Utrecht University and University Medical Center Utrecht for helping me with this project. Thank you for your attention.
Thank you, Irin, for your very interesting presentation. I'm going to ask Dr. Mike Kowaleski to make some comments.
Great, thanks, Ken. Thank you, Irin, for a fantastic presentation. I was curious, you mentioned that the lead time ideally would be 8 weeks, and that in your study it was longer because of various manufacturing issues. Obviously, and you showed that progression of OA can occur during that lead time, and certainly the prosthesis, the implant, may not fit well due to changes in the acetabular shape and so forth. So in the ideal world, what lead time would you target from the CT to the day of surgery?
In my experience, and actually now we are busy with the second cohort that we try to decrease the lead time from the previous one. From this cohort is a two months, approximately 2 months. Now we can decrease to 1 month. However, we still see some progression of osteoarthritis and joint capsule fibrosis in some patients. So I think ideally, if it's possible, I think 2 weeks is the best solution.
Great. And in 3D printing of patient-specific implants, PSIs, is a very hot topic. And there are certain manufacturing do's and don'ts. You should use a manufacturer that produces high-quality medical-grade implants. So I'm just curious, is your manufacturer one that produces similar human implants that are validated for use? Is it in-house? Or in other words, how do we know that the manufacturing process is as stringently controlled as it could be or should be?
Yes, actually the implant was designed by the 3D lab from human implant, and it was sent to the manufacturing that made the implant for human too. So the quality of the implant and quality of the titanium that was used for this one was tested multiple times to find which one is the best one and used in this study. And we already test for the biomechanical before we use in the real patient, before we use in the experimental dog. We test the biomechanical of the implant on the cadaver first, and then we go for the experimental dog, and then we came for the patient.
Super. And my next question has to do with longevity. Obviously, you've got an ingrowth surface with screw fixation cranially, but over the acetabulum, the device is basically loaded in a cantilever bending mode, and we may see a long-term fatigue failure at the junction of your acetabular part and your ingrowth part. So how long do you think you need to follow patients clinically before you can say this is a lifelong implant? Obviously, a year is relatively short. Would it be 5 years or 8 years or 10 years before we can say this works for life?
Yeah, I agree with that question. From the biomechanical testing, we test the implant, and we found that this implant can tolerate with the force around 1,300 newtons. But to be honest, now we follow the patient, the maximum, the first patient that we operate until now is 3 years, and the implant is still there and working good. But I think we have to make a longer follow-up to see that this implant is still strong enough to stay for the whole life. It's still in the progress of the follow-up.
Great. My next question has to do with outcome. You had multiple outcome measures. Some were radiographic, some were owner-reported, some were objective, like force plate. As a pet owner, my dog is limping, I want it to be fixed. Which of those outcome measures do you think is most important to me, the end user, when I see my patient, my dog, after surgery? Which one best reflects whether or not I think the dog is better?
Mostly when I talk with the owner after surgery, I usually ask what kind of the activity that the dog cannot do before surgery. And after surgery, can the dog do it better, or can the dog become better to do it like that? And many times the owner said the dog cannot stand on only the 2 legs, on the back leg. And after surgery, now the dog can stand on only the back leg. And Another thing is the how to say, the most of the dogs that have a hip dysplasia and enroll in this study is like an exercise intolerance or lameness after exercise. So after surgery, I asked the owner again that did you still see the lameness after exercise, or did the dog show any sign that doesn't show the improvement after surgery or not?
Okay,
So
good.
I mostly ask about the activity.
And I guess I'm looking more at the force plate data. And what the force plate data basically showed was that post-op limb loading was decreased, and that in the long term it increased, but only increased back to the pre-op level. And if the patient came in lame pre-op and ultimately was just as lame post-op, I'm not so sure that we've made a huge improvement in outcome. So my last question is, if you were to design a study to compare, for instance, total hip replacement to this procedure, what would your outcome measure be, and what time points would you use?
For the first plate, in this study, one thing that I think that I don't see the improvement, because firstly, we use the walking gait, which is very slow walk, that's only 0.8 to 1 meter per second that we control. And we didn't do the exercise before we do the first plate. So it may not show the lameness at the pre-op and also the post-op. So we don't see the improvement. So I think in the next one, we can adjust the protocol. Like we can change from the walking speed to running speed, and we can like do some activity to increase pain, or to see that the dog has a pain related with the condition, and then do the force plate after that. At least, maybe we can compare with, I think about compare with the control side. Actually, we have 7 dogs that have a unilateral hip surgery, but unfortunately, they didn't come back for the control every time. So finally, at the 1-year follow-up, I have only 3. And I cannot do the statistical analysis to see that it's improved or it's different or not.
Great.
And sorry, one more thing, that I think that the time at 3 months to 1 year that we see the force plate data come back to the control at 1 year is quite a long gap between 3 months and 1 year. So maybe we can add one more visit between that at like a 6 months to see that the dog come back to the pre-op value at 6 months or not.
Great. Well, thank you very much for a very interesting prospective study. It's a tremendous amount of work to have all these patients having surgery in such a short period of time.
Thank you.
Thank you, Irin, for your really interesting presentation, and we really appreciate you submitting your work to this symposium, and look forward to hearing more about it in the future. Thank you.
Thank you so much. I appreciated that.
For our next presentation, we're going to leave Europe and travel to Latin America, where Dr. Anderson Souza is going to give us his presentation. Good to have you on the program. Anderson, thank you.
Hello, Dr. Johnson. It's a pleasure to be here.
Hello, everyone. My name is Anderson Souza. I am a PhD student at the University of São Paulo in Brazil, and now I will talk about our study. The implantation method and type of the proximal screw don't affect stress and strain in equine pastern arthrodesis with lock-in compression plate. The pastern arthrodesis has been used for treatment of several conditions of the pastern region in the horses, and different techniques has been described along of the time. And you can use in just screw placed transarticularly, or this screw associate a plate in dorsal position of the joint. Currently, the AO Foundation has been recommended a 3-hole 4.5 narrow LCP specifically designed to pastern arthrodesis, associated with 2 5.5 mm transarticular screw placed in leg screw technique for pastern arthrodesis, except of course in case of the fracture of P2 and complete luxation of this joint. In addition, the unicortical implantation of the cortical screw in the proximal hole of the plate has been suggested to avoid the occurrence of stress-rising fracture in the proximal phalanx. However, using the cortical screw in this way doesn't allow efficient dynamic compression of the dorsal aspect of the joint by the plate and may affect the stability of this construct. And the stress and strain on the dorsal and palmar surface of the proximal phalanx after pastern arthrodesis has not yet been studied. For this, our objective with this study are to measure the stress and strain on the proximal part, proximal phalanx, and on the plate in the ex vivo model of equine pastern arthrodesis with different implantation methods and type of proximal screw in locking compression. Our hypotheses are regardless of the proximal of implantation, locking screws promote greater stress and strain than cortical screws, and screws applied bicortically would promote similar stress and strain profile on the dorsal and palmar surface on the proximal. Our study was approved by the ethical committee of our university, and we performed a pastern arthrodesis using a 3-hole 4.5 linear LCP associated with 2 5.5 millimeter transarticular cortical screw in 20 equine cadaveric limbs, split in 4 groups according to the type of proximal screw implantation. Where the GUC group, we used a 4.5 cortical screw placed unicortically, and GBC using the same screw but placed bicortically, and GUL using a 5 millimeter locking screw placed unicortically, and GVL using a 5 millimeter, same screw of course, placed bicortically. In this image we can see the different groups after they finish the implantation of the screws and the implants, and we can see a different in the proximal screw of the plate. It's important to say in the locking groups we're using a tensile device to do a dorsal compression of the joint. Using a strain gauge for measure the micro deformation in the bone in the plate. When we put a rosette in the dorsal and palmar surface of the P1 and axial gauge between the hole of the plate in the dorsal position and distal position. In this part we can see the details of the type of the sensor and position and the according of the X of the bone. We do axial compression mechanical testing until 2 times average body weight in 2 cycles, and we measure it in the gauges the maximum strain, minimum strain, angle of this principal strain, and shear strain ratio, and stress in different moments during the loading, equivalent to stance, walk, trot, gallop, and jump, according of the value of the load. For that data analysis, we perform a normality evaluation of the data using the Chairperson and Levin testing tests, and using the ANCOVA for compare stress and strain between the group on the same load and within the same group in different loads, using the body mass as a cofactor, and after compare between the group using the Bonferroni post hoc test. The significance was set at 5% and tendency to different set to 10%. And the effect size, it was calculated using the Cohen testing, and when we consider it a large effect when the value is larger than 8% or 0.8. As a result, the distal part of the plate showed great strain, around 5 times more than proximal part of the plate. We can see the difference of the graph. and the proximal screw had no influence in this boundary. The strain was generally greater than within the group at different load for gallop and jump versus stance and walking in the distal part of the plate here, different of this part. The shear strain was at least twice as high on the palmar side as on the dorsal side of the P1, but there were no difference between the group in the same loads. Between the loads into the groups on the palmar side, where there were higher value in the gallop and jump than the stance and walk. The stress values were much lower than those estimated for the failure of cortical bone and metal of the plate in tensile or compression, and stress was generally higher within the groups at different loads for gallop and jump versus stance and walk at the plate and pew. As a limitation, we can say the applied loads direction represent only one possible scenario among the various forces experienced by the pastern region during the equine movement. We didn't consider the influence of another anatomical structure such as ligament, tendon, and proximal and distal joint on the mechanical behavior of this region. And as a conclusion, we can say the palmar surface of the proximal phalanx is hybrid, higher stress and strain than the dorsal surface, as well as the part of the plate that is on the joint line, which is more demanded than the proximal part. In the evaluated loads, the axial loading of the constructor represented stress values much lower than those estimated to failure to occur in the analyzed materials, and the implantation method and type of the most proximal screw didn't have a relevant influence on the analyzed variable. But this is not a definitive conclusion, because more further analyses are being carried out, and probably it's possible to change this interpretation of this data. Like a clinical, as a clinical relevance, we can determine the use of the bicortical screw on the proximal hole of the plate in pastern arthrodesis didn't prove to be a critical factor in the generation of stress riser and can be used to achieve efficient dynamic compression. I would like to say thank you for some agencies, FAPESP, CAPS, and CNPq for financial support. I would like to say thank you for some University of São Paulo and University of Zurich for support of the study and interpretation of this data, and the companies Focus and Classical for support with the material of the study. I would like to say thank you for AO Foundation for opportunity to present my dates, and for my advisor, Professor André Zopa, for opportunity to do this study. Thank you very much for all.
Thank you, Anderson, for your very interesting presentation. I'm going to pass over now to Dr. Watkins to make a comment about your research. Thank you.
Thanks, Ken, and thank you, Anderson, for your presentation and all the work that you did with this project. I find it very interesting because, as you know, that's an area of specific interest for me, particularly with the aspects of the comparison of the strain and the stress in the phalanx relative to the method of screw implantation. Before we go to specific questions, you mentioned that you are doing further analyses. I was curious as to what you intended to analyze in more detail.
Yes, of course, Dr. Watkins. We have finished the analysis of the strain gauge data, because so many dates, and we need to analyze the direction of the load or the strain. And for analyze, we can see until now that the direction of the load during the loading of the specimens can change in function of the growth. And probably the standard technique using for actually can be changing more abruptly this direction of the load during the load of the specimens, and probably can be a risk of fracture. Some another papers has described this is a possible to be a risk of fracture of such a fracture of the P1, and probably I can decide for this conclusion after finishing this analysis. And this project is become a more great project. And the next step, I am building a finite element analysis, and probably I can check this scenario or in another scenario of the loading for checking this combination loads during the load of the limb can be changed during the in function of type of fixation, of course.
Thank you. That leads into my next question. You chose to put the specimens in pure axial compression. Just from observation of the way the horse is built and the way that the pastern sits in the leg and so forth and the way that it's loaded, what in your finite element analysis, how will you modify your testing mode to better define the effects of that unicortical versus that bicortical screw positioning?
Probably the first step in my finite element model is check the same condition for validated dates, of course, using the strain gauge date for validate. And after this, I check a combination of the loads, axial and plus the compression, axial loading, because it's more natural in the horses. And probably I can check more details about the surface of the bone and the stress concentration in another part, because the position of the sensor is restricted area of the bone, of course. I can check, it's possible to become another point of stress riser, but I can identify using the gauge, of course, and probably I can identify another point. And after this, I can change my conclusion.
Very good. So one of the premises or the questions that you answered was that the strain and the stress were basically the same regardless, at least with the cortical screws, which is if you're not going to use a compression generating device separate and you're going to use a dynamic compression principle of the plate, obviously that's the direction you have to go, that you didn't see any significant change or difference between the unicortical versus the bicortical. Did you appreciate, at least to me in those graphs, it looked like there was a trend for the bicortical screw to concentrate a bit higher stresses in the plate than the unicortical screw did. And then as I interpret that further and consider the fact that the top of the plate acts as a stress riser, and that a stress riser or a stress concentrator is really the function of the difference in the stress in that section of the area of the bone in the plate versus the non-plated area, it seems like there's a greater difference in the stress in the bicortical screw than at the unicortical screw. Was that anything that came to your attention during analysis of your data?
No, we can see during the mechanical testing, of course, this scenario is just a poor axial compression, of course. We say during the normal walking of the horse, I cannot just this type of the load occurring, of course, but probably when put the locking or bicortical screw, this screw not affect any difference in the bending after remove after test, of course, and not exit the bone, not bending or any forces in this proximal part of the bone of the P1. And so I can say probably this part is not so critical to the type of screw placed in this position. Okay. Yes, I guess another position is more critical. Another screw, of course, more critical to do this procedure.
Very good. So from a clinical standpoint, has it been, So one of the premises or the questions that you're trying to, you're looking at is the ability of a bicortical screw versus a monocortical screw to generate compression at the dorsal aspect of the pastern joint. Did you measure that in any of your testing, or did you actually evaluate that, or is that basically an assumption on your part?
I don't know if I can understand completely your question, but when using the unicortical or bicortical, in the first moment, I imagine that the unicortical application generate more strain, more stress or strain in the dorsal position, of course, because just this part of the bone is anchored in the plate when put the axle load, and the distal part or the distal cortex or palmar cortex in this case, I'm sorry, not more free to do the movement, of course, and not able to compression, do any mechanical force in this part. I don't know if I respond to your question.
Yeah, so I would just observe from a clinical standpoint of having done a few of these that, you know, if the screw sits down in the plate appropriately after it's tightened, whether it's monocortical or bicortical, that you generate equal degrees of compression. But I think that would be an interesting thing for you to test in your next analysis or in your next project. I know we're running out of time, so we really appreciate your talk here, and again, thanks for all you've done there.
Thank you very much, Dr. Watkins.
Thank you, Anderson, for your really interesting work. I know it's very challenging for someone to come into a symposium like this. It's a little bit daunting, and we really appreciate your effort in contributing today. It's good to see you. Thank you.
Thank you very much.
So I'm sure you'll agree that we've heard a range of different really interesting research ideas today. And just to wrap up, I'd like to call on the panel to give us some closing comments and ask you, Simon, first to give us your thoughts and wrap up about orthogonal plating.
Thanks, Ken. That was very interesting to get some really good benchtop data on the influence of the orthogonal plate, and yet another good method for managing situations where a fracture configuration forces us into a very long working length on a plate, which then runs the risk of plate failure. So adding the orthogonal plate is a really good approach for reducing that strain in the implant and making the construct have a much longer fatigue life and really protecting that implant. Obviously, as we discussed, balancing the added surgical intervention or trauma to the tissues has to be considered. But as Brett really nicely pointed out, often this is an approach that's being thought of because you've got a patient that has risk, either due to the severity of the fracture or the small fragment size and the inability to really get good purchase, or a very comminuted fracture forcing into a very long working length, which we know increases the strain and stress in the plate. So really nice to get some good solid data to support this this approach and help us with that decision making.
Thank you, Simon. And Matthew, what would you like to?
Well, I think Heidi's talk identified some real opportunities. We've got multinational studies that we want to be able to do, and we have linguistic barriers. So whether that's German, Spanish, Portuguese, these are important steps for us to become truly global in the way that we can access and leverage the cases. I think, for me, it was great to see the systematic approach, the way this was done. I think it is, as Heidi alluded, is complicated, and the importance of using linguists and translation services in that and doing it in a probably a more expensive way than would be done if you just decided to do it through Google Translate, I think is important. I think the other thing that stands out to me, it is going to be really important to recognize that even when they're validated, these OROMS, PROMs are validated for application. So we've got to be very careful at overextending them outside of their area of validation into other areas of practice simply because we haven't got any other tools. But I think in conjunction with the other things we do, for me, they're not a replacement for good objective outcomes. I think that came across in the earlier discussion regarding the relationship between force plates and questionnaires. We're going to have to work this out and see what is the most important and the most valid and responsive index for all of these things as we do, hopefully, more prospective multi-center trials.
Mm-hmm. Okay, thank you. Thanks, Matthew. Mike.
Yeah, I think Irin presented some very interesting work. It's clearly a new surgical procedure, and with any new surgical procedure, we need to be critical of several factors. What's the actual long-term outcome? How does it compare to other procedures for the same indication? Is it superior in outcome or inferior? Is it superior in complication rate or inferior? And then what about cost? Certainly a patient-specific implant versus an off-the-shelf implant, there's a big difference in potential cost. I think going forward, answers to these questions will be very important to decide whether this surgical technique is as good or better than total hip replacement, for instance, or perhaps it's not quite as good, costs more, takes longer to do, or some other factor that makes it inferior. But that's future investigation.
Sure. A lot of things to consider. Yeah.
Exactly.
Thank you. Jeffrey?
Anderson, he presented some very interesting information that I think we can take to the surgery table, and that it really, at least from the standpoint of in his testing methodologies, it didn't appear to make a big difference whether you use a unicortical or monocortical screw with respect to the amount of strain generated in the bone and the plate. I think he leaves a few questions unanswered. I think there's some things that are probably worthwhile for him to consider going forward. Again, the assumption that a bicortical screw produces superior compression at the dorsal joint surface than a unicortical screw needs to be validated. I think we also need to look further into the effect of not only a few cycles at low loads, but we need to look at some higher loading rates or some higher loads with some cyclic fatigue efforts to look at the effect of the stress concentration, which in my view is the real question. Now, from a clinical standpoint, I can tell you that I've seen this procedure done with all of the different methods that he described, and we don't have a high complication rate. The procedure continues to be the global standard for managing pastern degenerative joint disease in the horse. I think it's always good to move forward and get more information, but I certainly appreciate the work that he did. And I'd just like to tell you, Ken, thank you for putting this together. I'd like to congratulate the Research and Development Commission for sponsoring this and for their efforts in trying to continue to promote research within the AO family and to continue to globalize our efforts. So again, thanks for doing that, and it's really great to be here with all these incredibly good minds, and it's just been my pleasure to be part of this.
Thank you very much, Jeff, for your kind words. And so I want to say my thanks to all of the panel, to Simon, Matthew, Mike and Jeff for giving your time to be here today. I think you'll agree that we've achieved one of our aims, and that is to have young people come here and present their research in this forum. It's pretty intimidating to stand up there in front of a bunch of old guys like us and have to speak about your research, often in a language that's not your own native tongue. The other thing about the research is that research is a very incremental process, and you'll notice that any good research project, such as ones we've seen here today, raises another 20 more questions than what originally started out. And so that's really the process, that you're never going to have the final answer. You aren't going to have the final cure for cancer just in this one project, that it's step by step, well-designed studies, well-thought-out projects to build on this knowledge and to repeat it, make sure that it's valid. I hope that in the future we can repeat this symposium, because I think it's really a valuable opportunity that we spoke about before to encourage young surgeons to get involved with research, to understand research and contribute to it, even if it's only in a small way, but it's a meaningful sort of thing for them to do as part of their professional life. So thank you all for being here. It's been a lot of fun.